I'm so excited to be joining you here from Los Angeles and to be able to talk to a global and a national group of medical students interested in neurosurgery, the MSNTC, the Medical Student Neurosurgery Training Center. Great name, excellent branding. And I know Ryan Radowski, so he's one of the founders. And Michael Rao, I just want to thank you so much for letting me introduce the meningiomas. And so let's get started talking about meningiomas. I really like neurosurgery. It's pretty obvious. And I really like neurosurgery, brain tumors. I love treating brain tumors with neurosurgery, radiosurgery, the whole gamut. And so if I were thinking like a medical student, if I were a fourth, third, second, or first year medical student, I want to try to separate the trees from the forest. What's the important stuff? What's the not so important stuff? The first place you want to start with are what are the most common brain tumors? Meningiomas, absolutely. Glioblastomas, absolutely. And metastases. If you just want to go by pure numbers, the most common extraaxial brain tumor, meningioma. The most common intraaxial tumor, glioblastoma. And then the most common tumor, maybe by numbers, because that whole cohort, lung cancer, breast cancer, kidney, skin, GI cancers, those cancer patients are now living longer and longer. And so they have more metastasized to the brain. So if you just go by sheer numbers, those three are going to be continually at the top of the list. And those are the ones that you're going to have to know about as a student to go into neurosurgery. And also because you're going to be dealing with questions as residents and attendings ask you, what do you know about meningiomas? And when I think about meningiomas, I first want to think about embryology. And I know I literally can hear you groan over the internet. Maybe that's just everyone collectively groaning. I can hear you in Los Angeles. Embryology. I know. I hated embryology too when I was a med student. I still hate it now. Okay, that's just full disclosure. But for a second, let's stop and think. The brain is what? The brain is ectoderm. The brain is just skin cells. Really, we should be a subfield of dermatology, right? Brain is just specialized skin cells. It blows my mind when I think about that in that way. But when I want to stop and think, the reason I'm bringing it up is because if brain is ectoderm on the inside, then what's the origination of meningiomas and the meninges and the arachnoid cap cells? These are coming from the mesoderm, a different layer. And so these are not intraaxial tumors. These are tumors that are occurring from the meninges. You have the covering, the dura mater, right? You have the arachnoid and you have the pia. And the pia is stuck to the brain, but the meninges comes from the mesoderm. And so this tumor comes from the arachnoid cap cells, the junction of the brain itself proper, the arachnoid, and then you have the mesoderm, the meninges. And so this is where the tumor is coming from. And this junctional point, for some reason, leads to tumors. For example, when you look at acoustic neuromas, another tumor I really, really like is that when you're looking from the junction of oligodendrocytes to Schwann cells, from the central nervous system to the peripheral nervous system, that's the junction where acoustic neuromas occur. And this is the junction where meningiomas are tumors that come from the meninges. One of the really interesting things are that meningiomas are more common in women versus men. They have a higher propensity in women versus men. And we think it's related to hormones because that's one of the differentiating factors between women and men. And some of the more common or famous women that are known to have them in the news are like Sheryl Crow, Mary Tyler Moore. Popular figures have been known to have meningiomas. Conversely, though, even though they're less likely in men, the higher grade tumors, the atypicals and the more malignant meningiomas, they are more common in men. And there are genetic mutations that we know that are associated with meningiomas. The first one is NF2. And I know you're all medical students. So neurofibromatosis. Neurofibromatosis number one, if you remember the mnemonic, there's 17 letters in neurofibromatosis. I can barely spell it. I can't spell it. But there are 17 letters, and that mutation occurs on gene 17. I'm sorry to teach. I can't help it. eons and decades ago, I used to be an MCAT teacher. And so it's still just, it's in my soul. And I just feel like I'm a neurosurgery MCAT teacher, except there's no MCAT for neurosurgery. NF2, neurofibromatosis 2, is pathognomically diagnosed with 2 acoustic neuromas. And it's a problem on the gene 22. So again, something kind of there, I want to plug that in, neurofibromatosis 2. And it's most commonly diagnosed pathognomically with 2 acoustic neuromas, bilateral acoustic neuromas. But patients who have that are more likely to have meningiomas. You can also get meningiomas through ionizing radiation. So the common place we see that, young children who get leukemias or lymphoma, they're treated with radiation, they survive their cancer, and 20 years later, they have a radiation-induced meningiomas. And the science is uncertain, but there are literature reports of different hormones, like we talked about, women versus men, and head trauma, but it's unclear. Until one of you here identifies the cause of meningiomas, at this point in my life, I don't know. But someone here I know is smarter than me, probably all of you, and that you'll be able to find what is the cause of these meningiomas. Now, neurosurgeons, we love grading scales. Oh, we love grading scales. We're going to grade everything. How sunny is it? Is it a 1 through 5 grading scale? We are just born with grading scales. Questions that you may be asked. What's the Spetzler-Martin grading scale? Well, it's 1 through 5. And you're going to see we have 2 grading scales here that hopefully you'll take away. The first one is the WHO grading scale for meningiomas. Grade 1, grade 2, and grade 3. And the way I think about this is something called the good, the bad, and the ugly. And I'm pretty certain no one here has seen that movie, but it's an old classic movie with Clint Eastwood. But the good, the bad, and the ugly, the way you want to remember. Grade 1 is good, grade 2 is bad, and grade 3 is ugly. Most tumors are grade 1 and they're benign. And so we're going to expect a lot of women to have that. We talked about the incidence of atypicals and malignants are higher in men, and that's grade 2, the atypicals, more aggressive. And grade 3 is cancer, anaplastic malignant meningiomas. They recur, they grow so fast. So you have the good and cancer, and you have something in between. That's a grade 2. And most tumors are grade 1, about 80%, and 20% are the other bad kind. One of the things that you may want to know if you really want to score points talking to a neuro-oncologist or a brain doctor focused on tumors is that they keep changing the criterion for grade 2s. And so this is the most recent one in 2016. You can look at that, and I'll just leave that for you guys to know and learn on your own. And this is the criteria for grading scale in grade 3. HPF stands for high-powered field. They're looking for the mitotic index, and this is something for grade 2 is the brain invasion. Those are little pathological things. And so how do you treat meningiomas? And the first place you got to talk about, when you talk about patients, because one day you're going to be a neurosurgeon. And when you're treating patients, the first thing to know about meningiomas, if these are truly benign, slow-growing tumors, and that's what they are. They're slow-growing benign tumors. If they're grade 1, they're benign tumors and they're slow-growing. Sometimes less is more. Can you watch them? And I would advocate that if you have an older patient, and how you define older, that's going to change as you go through your career. But if you have a small meningioma and there are no symptoms, and people are asking, what's small? I'm going to ballpark that at 1 inch, 2.5 centimeters. If you have a small meningioma that's smaller than 1 inch that has no symptoms, then perhaps that's a tumor you want to watch. Now, if the patient's young, you may want to intervene, and that really varies. And so this is the example. Here, you can see the meningioma. And when I look at an MRI, the first thing I'm going to do is this a CT scan or an MRI? And this is an MRI because I can see the brain structure well. Is this a T1 or T2? Well, the gray matter is gray. The white matter is white. This is a T1. The nasopharyngees enhance. The sinus enhances. This is a T1 with contrast. And here you see the superior sagittal sinus. You see the structure down the middle, this the fulx, and you see this, I want to say booger, but I'm a neurosurgery faculty about to become full professor. I don't think I'm supposed to use the word booger. See this little thingy? This thing that does not belong? This is the meningioma. This is a falcine meningioma. And this tumor is small. This tumor does not require surgery. And if this patient is 40, 45, 50, whatever you want to define as old, I'd say just watch. If they're 20, 25, I'd say you just watch, but at some point they're probably going to need surgery because they're going to live such a long time, the tumor is going to grow. But this is a small tumor, and this is found incidentally. And the rate of incidental tumors, it's going to go up because we're scanning people. There's more and more MRIs. Back in the 80s, you could barely get an MRI. Today, I think at some point there might be an MRI at every airport. Instead of like TSA pre-checking you, they're just going to zip, 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 and scan you, because the prevalence and the incidence and the availability of MRI is going up. And so every time someone gets into a car accident, bonks their head, falls down, you're going to find more and more of these incidental meningiomas. And my recommendation is that sometimes less is more. If the tumor is small, it's asymptomatic, and the patient's older, the first thing is you may want to watch. Now, you could sit there and go, well, Dr. Yang, that's just your opinion. You're out to lunch. I'm going to push back and say, well, let's look at the science and the data. This is from some of my colleagues, Dr. Cahill, Dr. Klaus. They're from a small school called Harvard, okay, in Boston. And they did this enormous study. And here, if you can see, in this overall analysis of meningiomas treated in the nation, in the country, about half of these tumors were observed. About half of the 47% of these tumors were no surgery or biopsy. These tumors were observed. And so they were not treated with intervention. And that breakdown works down just like this, where most of these tumors were in women and less in men. And that if you look at their 1 year and 3 year survival, it's going to be quite good. This is not cancer. This is a slow growing benign tumor. And so because it's not cancer, we need to treat this tumor in kind. If it's a cancer, I understand. You got to go big, you go crazy, you're desperate. But this isn't cancer. This is a slow growing benign tumor. You don't know how fast it's growing. You don't know how long it's been there. Those are things you need to figure out. How old is the patient? Is it symptomatic? And those are the things that go into the decision-making of how you treat them. One of the ways that we can treat it is with radiosurgery. Okay, this is a technique developed by a neurosurgeon. And because of that, it is focused radiation. It is focused radiation that they're using to treat meningiomas. And this is a paper by Dr. Zada, one of my very close friends and colleagues at USC, looking at gamma knife radiosurgery for meningiomas. And here, the 5 year and 10 year actuarial progression-free tumor control rates were 99% and 84%. And these were all meningiomas. They were not biopsy confirmed. They were just imaging diagnosed meningiomas. Somewhere around 90% of these tumors were controlled for 10 years. It's a remarkable treatment rate. It's something that has to be considered. So when you're looking at meningiomas, you have to first keep your surgical instincts and your desire to do surgery in check because it's the right thing for the patient. Can you observe? Can you do less is more? And then number two is, if you are looking at a 10 to 20, 25 year horizon, is radiation an option? Because if it really has a 90 to 95% control rate over 20 years, then you're looking at a possible curative option, that radiation can be a possibility. But radiosurgery and radiation cannot improve symptoms. It stops the tumor right where it's at, but it doesn't make it smaller. It doesn't improve symptoms. This is from one of my good friends, Dr. Shagru. And you see here another falcine meningioma, an anterior fossa, big tumor. This tumor is causing symptoms. This tumor is way bigger than 2.5 centimeters. This tumor cannot be treated with watching. This tumor cannot be treated with radiation. This tumor needs to be treated with surgery. And this is the patient's visual field where you can see that the patient's already having a visual impact. Okay, this is not a bitemporal hemianopsia, by the way. That's what you expect with a pituitary lesion, right? This is a binasal impact. And what happened to this patient is over time, the patient presented with complete right vision loss. And so we took the patient to surgery, and this is the MRI after tumor resection, tumor surgeons, we have to show these pictures. It's like we go hunting, and I've actually never gone hunting. I've actually never fired a gun, so that's the wrong analogy. But trophies. This is the trophy. See the tumor's resected, voila. But what's really cool here is the patient's vision improved. Okay, we didn't go back to perfect, but what you see here is that the patient's vision was completely out before surgery. And when you remove a tumor like that and you take the pressure off the brain and the optic apparatus, you can make the vision better. That symptoms can be improved with surgical interventions. Usually symptoms cannot be improved with radiation. You're taking the patient where they're at and keeping them where they're at. And going blind in one eye is usually not the best option. This is a image from a paper from my friend John Chi, who's at Harvard Brigham as well. And here you can see a small tumor right here in C1, but you see there's edema, T2 edema. See these T2, the gray matter is lighter, the white matter is black. And here on this imaging, this FLAIR imaging, fluid attenuated inverse sequence, you can see that this tumor is surrounded by white. Okay, it's not surrounded by white here on the T1 with contrast, but on the FLAIR imaging, there's peritumoral edema. This is a much larger tumor, and there's also much more substantial peritumoral edema. If you have a lot of swelling around the tumor, that's a much more indicative sign that you need surgery. It's not a sign that radiosurgery or radiation cannot work, but it's less ideal. And here you can see more examples of peritumoral edema. What they found in this paper by Dr. John Chi is that patients' visual outcomes, they could be improved with surgery, and that this varied based on size and peritumoral edema. The last thing about surgery, before we move on to really other topics about meningiomas, I told you that neurosurgeons love grading scales. We do. It's just in our blood. And if you're talking about meningiomas, a very, very likely question that anyone could ask you is, what is the Simpson grading scale? You say AVM, I say Spitzer-Martin. It's just 1 and 2. You say meningioma, I say Simpson grading scale. You say glioblastoma, I say what grade, 1, 2, 3, 4 is it? It's just, these are things that are in our lexicon, that when you're saying that disease, you might as well be saying Simpson grading scale. And so if you don't know the Simpson grading scale, you're going to look like you don't know the language or the alphabet or the bare basics, the very basics of brain tumors and or neurosurgery. So the grading scale goes 1 through 5, 1, 2, 3, 4, 5. And it's really best if you just put the biggest margins at the separate areas. Okay, so 5 is just a biopsy. 5 is just a biopsy. Simpson 1 is when you take out the entire tumor and you take out the dura, because the tumor is coming from the dura. So you're taking out the entire tumor and its birthplace. That's a Simpson grade 1, the whole tumor out. Simpson grade 2 is where you take the whole tumor out and you coagulate the dura. You don't cut the dura out. You weren't able to, so you leave the dura there and you bipolar it. Simpson 3 is you take the whole tumor out and you just leave the dura alone. You don't do anything to the dura. It's just there. And then 4 is a subtotal resection. That's Simpson 4. And a 5 is a biopsy. 5 is a biopsy. I think most times you're going to see Simpson 1, a Simpson 2, rarely a Simpson 3, and more likely a Simpson 4. And the reason why Simpson grades are important is because they portend to the recurrence rate. That if you get a Simpson 1 resection, the rate of recurrence for the meningioma is going to be less. And where it gets a little messy was, well, what if you get a Simpson 1 on a grade 2 meningioma? Well, I think the recurrence rate was also less, but not as good as if you got a grade 1 Simpson 1. And so you really want a grade 1 meningioma with a Simpson 1 resection. That's the ideal. But the molecular pathology, whether it's a grade 1, grade 2, or grade 3 meningioma, affects the Simpson grading scale, which is 1, 2, 3, 4, 5. And I know that's a lot of numbers, but they're really important to know if you're going to walk into the OR or if you're going to have a conversation about meningiomas with a surgeon, because they're going to be thinking about these things. These are the things that are part of their lexicon. Well, one of the reasons I went to neurosurgery and why I still love neurosurgery and why I think you all should think about neurosurgery is they call it neurosurgeons with a lot of toys. I don't know if it's toys, but there's a lot of technology. Neurosurgeons use a lot of technology, whether it's AI or robotics or computers or VR or AR. We're always on the cusp of pushing the envelope with technology. And I am a very technologically, I like tech. I really like computers. I really like trying to do things that are on cutting edge. And this is from a company called Surgical Theater that was working with us here at UCLA. And here you can see that we are making a virtual reality approach to a meningioma. And you can see this is an anterior fossa meningioma. And you can look inside the skull and see all the major blood vessels. You can see the anterior cerebral arteries. You can see the carotids. You can see the middle cerebral arteries. And you can see this tumor in its relation to those blood vessels, because we can move around in 3 dimensions. And I think this is so cool. I think this is going to change the way that the young people here in this virtual room, I mean, think about this. This was impossible to have a FaceTime or a Zoom conversation. When I was in high school or college, I would have never believed this was Jetsons to me. But the way you're looking at this tumor is so different than the way I looked at tumors. When I looked at tumors in my residency, it was on 2D film, like black and white. And I think as computer power gets better, as this kind of imaging gets better, no one's going to be looking at screens. You're going to be looking at 3D projections, HoloLens. Images that you will be looking at will be different than the way images I look. I'm looking at MRI T1, T2, and this isn't, what is this? This is T1, T2. This is a 3-dimensional virtual reality space where you can move and manipulate. The way you're going to be looking at things are so different. It's so important to learn the basics, which are the anatomy, but the way you're going to be looking at it is very different because technology is different. One of the ways we want to look at meningiomas and the meningioma surgeries we do, we're looking at blood transfusions. How do we know which one of these patients are going to need transfusions when we do these surgeries? And so one of my fellows, Dr. Logman, who's now a neurosurgery resident, did a retrospective study looking at the meningiomas that we did surgery on. And what they found here was that when meningiomas were 5 centimeters or longer, bigger, or if the operative time took about 10 hours. Now, the first thing that you should take away if you've never been in the OR or you're not a neurosurgery resident or medical student in neurosurgery is, are you kidding me? 10 hours? And I'm saying yes. The average surgery is going to be 6 to 8 hours, depending on the size. But if you have a 5 centimeter tumor, your surgery is going to push 10 hours. And so if you don't love what we're doing or you don't love surgery or neurosurgery, 10 hours, I mean, imagine trying to watch Netflix for 10 hours. That's hard. Even if you love the show. Now imagine trying to watch Netflix of a show you hate. That's really hard. Brain surgery, when we're in the flow and in the zone and you're enjoying what you do, those 10 hours pass like this. But when the surgery is approaching 10 hours or more and the tumor is 5 centimeters or bigger, your risk for transfusion starts going up and up. And so what we try to create is a 10-5 rule. If the surgery is approaching 10 hours or it's 5 centimeter or bigger meningioma, everyone in that OR, including anesthesia, the medical students, the residents, and the attending, should be concerned that this patient may need a blood transfusion because this is that cohort of patients. And if you want the specifics, Dr. Al-Khalid, Dr. Logman, Dr. Shepard, these are the doctors who did the study, and you can look that up in another paper. If you're going to look at tumors before surgery, one of the things we can do before we operate and cut the tumor out is we can do an embolization. We can stop the blood flow that goes to the tumor and go in and cut the tumor out. And so this is called embolization. And what we were trying to find is which tumors do we embolize and which tumors do we not embolize. And we use a semi-automated process, computer, to help us with that. Remember that meningioma we saw in 3 dimensions? This is that tumor. And if you could see that tumor and if the computer can segment what is the tumor automatically, based on the contrast enhancement. I'm waving my hand as if you could see me pointing to the screen. Sorry. If you can see the tumor here and see it now, the tumor is being segmented based on its contrast enhancement. You see, and now the computer recognizes what is tumor and what is not tumor, what is brain, what is mesoderm versus ectoderm. And if you're looking inside the tumor, what we can do next is we can then see what are the flow voids. How many blood vessels and how big are the blood vessels in this area? And if you add it all together, what is the volume of all those blood vessels? And we found that if the MVI, the meningioma vascularity index, is less than 2.5 cc's, you probably don't need to embolize. Whereas here, this is a different meningioma and the MVI is greater than 2.5 cc's. This is a tumor that is very helpful to embolize. It's going to make a difference in this patient's surgery. And this is a different tumor that's MVI greater than 2.5 cc's. And so what we found was that controlling for tumor size, bigger tumor, small tumor, doesn't matter, that the risk of blood transfusion went up when the MVI was higher. But more importantly, we found out that those patients who got embolized, they lowered their risk for transfusion, and that the MVI predicted which patients needed embolization and which didn't. And it was based on the MVI. And this was published in the Journal of Neurosurgery. Again, Dr. Logman was our neurosurgery fellow, and Dr. Reza Jahan, he's a neurointerventionalist here at UCLA who helped us with that study, and you can get those papers. So the final frontier of meningiomas is not going to be surgery. It's not going to be radiation. It's going to be molecular genetics. This is the future. This is where you all are on the cusp of knowing the future. Because if this is a chromosome 22 abnormality, and that's an NF2, and that you see that there's this difference in genetic abnormalities, you young people who will be neurosurgeons in the future, you'll have a better way to treat it. You will look at the way I treated it, and you will laugh. And I will be long and gone, and I will accept your laughter, right? Because we look at people who used to use Thomas guides and go, well, what was that? Payphones, right? Just a generation ago, it was payphones. You're gonna look at, well, people rode horses to work? No. And you're gonna look at me and go, oh, Dr. Yang drove a car and drove it himself. That's archaic. The future of tumor treatments and meningioma treatments is gonna be genetics. It's gonna be how you look at all these chromosomal alterations. That for atypical meningiomas, WHO grade 2, there's a lot of chromosome 1 deletions. For WHO grade 3, they're much, much higher. And that these 1p14q deletions, I know it sounds like alphabet soup, but these different kinds of deletions and chromosomal abnormalities are going to help you define which tumors, how they behave, what their growth rate is, and what their prognosis is. And this is a paper by Dr. Yu, who's actually now currently a spine surgeon at the Leahy Clinic in Boston, and he helped put this together. But I do think this is the future, that we're going to find the molecular and genetic fingerprint of gliomas, meningiomas, brain tumors, and instead of treating everyone the same, like McDonald's, in and out, same Happy Meal, everyone, we're going to get a different profile based on all these patients. And I'm going to end with serendipity and luck. Michael introduced and said that I was an NIH-funded lab and stuff like that. And I just want to pause because, for full disclosure, I'm not an NIH-funded scientist. I have zero NIH funding, and I'm just not a real scientist, and that's okay. I'm just going to keep working and doing my best. And I probably will never have NIH funding, and that's okay too. I'm just telling you the truth. It's okay. But what we do have is a real, energetic, passionate cohort of scientists and researchers working together to study brain tumors, even without NIH funding. Just institutional grants. And we have a North American Skull-Based Society grant, so thank you. I have to plug them. And so we have a grant from the North American Skull-Based Society. Oh, their meeting is in a few weeks, so I have to plug that too. I hope to see you there. So there's a structure called EMP2, and I know it's more alphabet soup, but it's a marker on the surface of cells. And we were studying this in glioblastoma because that's another brain tumor. We talked about the most common brain tumors, and in brain cancer, we were looking at it. And we found that EMP2 is more correlated to the cancers, glioblastoma, and less correlated with the low-grade tumors. I know you thought I was talking about meningiomas. Trust me, I'm getting there. And you can see these circles. This is called tissue microarray, where you take circles of all these different kinds of tumors, you put it in a giant array, like a huge row of these tiny circles, and then you can mass stain all of them for different things. And this is that paper. We were looking at tissue microarray, and there was a whole bunch of slots, like 100 slots, hundreds and hundreds of slots, and we had a few slots that were open. And my fellow at the time, Dr. Chung, who's now a neurosurgery resident at USC, and Dr. Prolargos, who was a neurosurgery resident currently at Oklahoma, they were like, Isaac, there's these 3 slots. What do we do? Should we just run it? And I was like, no, I don't care if you spit in those 3 slots, anything. Just don't waste those 3 slots. Well, what we did was we put meningiomas into the slot, and we found that meningioma stained for EMP2. I thought this was contamination. When they brought it back to me, I said, this is wrong. This can't be right. Ha ha, funny joke. Ha ha, go back, do it again. Well, they did it on a few samples. Here you can see they did 1, 2, 3, 4, 5, 6, 7 samples, and they all stained for EMP2. I said, well, that's a little funny. It's possible to get 1 contamination. It's hard to get 7. And this started becoming a topic of study in our laboratory, because here you can see a meningioma. This is in the planum. This is in the pituitary region. This is in the sella. It's completely encapsulating the carotid artery. That's what the arrows point to. You will never, ever be able to resect this tumor. I do not care if you are God, the surgeon himself. This tumor cannot be resected in its entirety. So if it's not, what are other ways we can target this meningioma? And I think EMP2 is going to be really a cool way to target it, because we found that's increased in meningiomas. And we also found that it's not in non-pathologic dura or brain. So you don't see it in normal brain, you don't see it in normal dura, but you only see it in meningiomas. And so this is a target that we can attack. And so we ultimately did 16 patients, and we found that it's expressed in all 16 patients. I still hate the 100% rate, but that's what it is. That's what the science shows. We use this to get the North American Skull Base study data. And I can currently tell you the most up-to-date data is that we have now done over almost 40 of these tumors, and we're still finding the same EMP2 expression. You're the first people to know this. We haven't published this. We are going to write this up. We're going to present it at North American Skull Base Society 2023. But we're in the middle of this study. And just to give you the preliminary heads up, and if it sounds like I'm excited, you betcha I'm excited. I love it. I've been studying this tumor my entire adult life. And to find something that's in all these tumors, that gives us hope that if we can target them with a chemotherapy or a radioactive material, or even make them glow, like my friend Dr. John Lee at UPenn is making these tumors grow, that we will have a more targeted way to identify and treat these tumors. And if you want the specifics of this, this is written up by my chief resident, Dr. Kunal Patel, who's currently the chief resident here at UCLA, and this is in the Journal of Neuro-Oncology. Those are the details there for this paper. But yeah, I do think the future is molecular therapy. This one was published by Dr. Choi, who's a neurosurgery resident at UCSF, more than a decade ago, thinking that the future of treatments are not going to be surgery and radiation, but it's going to be molecular therapy. I don't do this work by myself. I hope there's no misconception. Remember, I told you I'm not NIH funded. I'm not a real scientist, but I am surrounded by real scientists. I am surrounded by really smart people. And these are some of the smart people here, including the medical students, the fellows, and the undergrads that are in our lab. They're really the scientists, the smart people, the researcher that I'm just honored to present our work together. There's the whole UCLA brain tumor program. Everyone has a role. Everyone is part of the team. This just can't be done in isolation. I have to thank them. And if you have any questions, please hit me up. You can send me an email if you're old like me. If you're young, you can DM me on social media, Instagram, Twitter, Facebook, and I'm always happy to discuss tumors with you. Thank you for listening.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to to keep our content available for medical students across the world.